So case 1. So I just want to get through that stuff there so you guys can have a good basis, but now we can actually discuss some cases here. So this is a 6-7-year-old male who's got chronic kidney disease on hemodialysis. He's admitted with community-acquired pneumonia, undergoes hemodialysis for 4 liters of suspected volume overload. 1 hour post-hemodialysis has progressive hypertension and a systolic pressure of 70/40, and heart's 110. So here's the image. So let's just describe what we see here. First of all, what view is this? Parasternal long axis. Great. Okay. So whenever I look at an image, I always think of acronym DAG. Okay, and that's depth, angle, and gain. So first of all, depth. So how are we for depth here? It's fine. Yep. Yep. So we can see an adequate amount of the pericardial space. We can see posterior to that. The depth is fine. Okay. But now the important part of that is that if you don't adjust the depth enough, you may cut off the image at the inferior wall, and you may not see an effusion because you simply can't see an effusion. So 16 to 18 centimeters is generally a good level for most cardiac imaging. Now the angle is nice because we have the aortic valve, mitral valve lined up, perpendicular, okay, to the probe. And the gain, okay, now gain is, what gain really is how the machine is interpreting a returning signal, okay? And so if I turn the gain up here, we'd actually see kind of more white and more hyperechoic. And these spaces which are anechoic may have more white signal, okay? And that's because you're turning up the noise and the signal is diminishing, okay? So these intercavitary spaces should be black, okay? Unless, of course, there's hematoma or pus in them, okay? So gain, that's your depth, angle, and gain. So this is a nice image. Now, what do we see? What is kind of most striking in this image here? Yeah, so we see an effusion, right? Yeah. So do you want to use that? I'll actually kind of point along with you. It's the green one. Yeah. It's seen anteriorly as well, right? Yeah. Excellent. Yes. So we're kind of 2 important things there. We're seeing separation of the inferior wall. We're seeing it go anterior to the second thoracic aorta, and we're seeing in the anterior space as well. Okay. Now, just looking at this, what do you think about? I mean, this is not our main focus, but what do you think about the left ventricle here? Any impression of what you see there?
Definitely, I would say reduced EF, so it should be not that expert.
That's fine. No, that's fine. You know, if I were to compare you, it's not really, the main focus of this talk is not on left ventricular function, but this LV function is grossly reduced, okay? And the percentage is not the main focus. The focus is really that there's probably a reduction in function here, right? Which I think you noticed, okay? And that's really the main point. You know, if we want to get exact numbers and precision, we can talk with our colleagues in cardiology, but the point is at the bedside, what you can determine from the images you have, okay? Now, determining size, yeah, it's probably small to moderate, but again, you want some more views, okay, to really build up that understanding. Because if you didn't see this, okay, and you just saw this posterior component, but you saw it nowhere else, well, I mean, it's hard to say exactly what the relevance of that is, right? So again, left atrium, left ventricle, aortic valve, aorta, RV, RVOT, okay. In this view, we can't. It's hard to really comment much on the RV, RVOT here. We can see it moving a lot, but it doesn't really point to any specific features. Again, it's saying thoracic aorta. Okay, let's get back to you there. So this is which view is this?
Short axis.
Short axis. Excellent. Let me give Adam here, this is the green one there.
Did I break something?
No. Just the green button. The green button. Top. Yeah, there you go. Okay.
So LV, RV, we see anterior, there's a circumferential fluid surrounding the heart, it's anechoic. Overall, looking at the LV, it doesn't look like you have great LV function. There's not a lot of squeeze here looking. Yeah, I think that's kind of most of what I see. You know, the LV doesn't look great.
Yeah.
There's circumferential fluid.
That's great. Okay, even that alone is important information. Okay, because now we've seen it in 2 views. We've seen it go anterior to the thoracic aorta. Okay, this is obviously, I say based on this alone, this is certainly a pericardial effusion. Okay, the LV again, we look at function. It's important in this view that the cavity of the LV is circular at end systole and end diastole, okay? Because if it's more oval, you could be off axis, okay? And that'll become more apparent as you guys do some more hands-on sessions on how to obtain a proper short axis view. Now here's your apical forechamber. Now who wants to take a stab at this view here?
Actually is, so if we start with the right atrium,
Right atrium, yep.
Collapse.
Okay, seeing some collapse there, yeah.
And then also with the RV, bit of collapse there.
Yep. Not much of a cavity, right, compared to the RV to the LV?
Yeah.
Yeah.
And of course, actually, as we can see, the left ventricle is fairly squeezing.
Yeah, exactly. So it's not, we determined from other views that the actual LV function is probably, at least, it's a depressed LV function, I think is important to take home. And again, we see that nice anechoic space, which is, we're seeing, we think, at least some compression there of the right atrium. Okay. Now we don't have an ECG waveform here, so it's hard to say when this is occurring. But if you look at the actual tricuspid valve, when the tricuspid valve opens, that's when you see this. That's when you see the collapse. And again, the longer that collapse is, okay, during diastole, the more significant that is a finding for pericardial tamponade. Excellent. Okay, and this is a nice view here again of your apical forechamber. It's the heart should look like a football in this view, and not like a soccer ball, for example, or a sphere. And that means when it looks more like a football, it's non-foreshortened, because you want to see the true apex. Okay, and so here's our subcostal forechamber view. And obviously, again, we can further see that there is some collapse of the right atrium, not much filling of the RV in that large anechoic space. We can see there's left ventricle, right atrium, left atrium, and so not much filling of the RV cavity, and again, more of those features. Here's the IVC. Okay, so we see that distinct finding again of that plethoric IVC that's quite dilated. There's no measurement here, but this is each around a centimeter, so it's over. I think this actually measured around 2.5 centimeters. And again, you're seeing that kind of smoke or that stasis in the IVC, and not much fluctuation there. That's using M mode. If the patient doesn't have much motion of the IVC, what M mode actually is the y-axis is the graphical display. This is like this was the first generation ultrasound type thing, where on the y-axis we have the image, and the x-axis we have time. Okay, so this is actually not space. This is one image which is repeated in time. Okay, and so what we'd be looking for is a change in size, and you can look at the top left here, 2.1 versus 2.17. So obviously not much of a change there, right? And really, it's 50%. Is less 50% would help determine whether it's plethoric and juicy. Now, there's a drain insertion here, and just sweeping through, you can see it right there. So it hasn't had a lot of drainage. There's still some pleural pericardial fluid there, but you can see there's less collapse of the right atrium and the right ventricle. But this patient did clinically improve even with the drainage of a small amount of pericardial fluid. So case summary, patient with chronic kidney disease undergoes lots of fluid removal. They develop clinical and echocardiographic features of tamponade. So learning points, effusion should be seen in multiple views, may be accompanied by RA and RV chamber collapse. IVC plethora is highly sensitive. Okay, and so if you see a flat, collapsible IVC, the chance that they have tamponade is very, very low. Okay, it's not impossible, but it's very low. Okay. So this is a patient, 67-year-old female, fear MI, elective AAA. She had her induction for her AAA, and basically crashed in the operating room, required around 4 liters of fluid and multiple vasopressors. Obviously, the OR was aborted. Patient was brought to the ICU, intubated. And so this was a very, very sick lady on a lot of, at the time, she's on a lot of vasopressin and norepi and epi. And so this was the first view we could see. Now, keep in mind, this was post 6 liters of fluid, and at this point in time, she was actually weaning down a bit on her no-repi. But what do you guys see here?
Maybe pretty large pericardial effusion.
Yeah,
it's
pretty large
obvious.
effusion, right?
And almost trying to look at the axis. If that's a 4-chamber axis, then it's really compressed throughout. So
Yeah.
It's so hard to tell because everything is collapsed.
Yes,
for the
so
heart.
this would be the LV.
Yeah.
That'd be the RV.
So
Okay,
yeah.
and this is probably
Mostly collapsed.
at a fat. Okay, it also could be a malignancy, but we think it's fat. Okay, for this lady at the time, it was difficult to separate, and she was obviously an extremis. But so we see this large effusion. Okay, the RV, we can't see the RA very well. Okay, and so I'm always cautious if I can't see something very well, then I say I just can't see it very well, right? Because you can't. The RV itself, I think if you timed it, you might say, well, it could just be collapsing with systole, and that's what it should be doing, right? So it's hard to say based on this image alone if she's still in tamponade, and I would have my doubts. Okay, the RV is it's not demonstrating a significant amount of collapse, and it's pretty open there. So, but again, it's the clinical circumstance. Okay, if you took away that 6 liters of fluid and put this patient on a 100 propofol, you can bet your dollar they'd be in tamponade, because that would decrease their preload, and it would change their balance with their intrapericardial pressures enough to cause tamponade.
Brian, can you give some advice on how quickly this scan should be done? Because that's the patient in extremis.
Yep.
You see something horrible.
Yep.
You're pretty sure it's tamponade.
Yes. So.
How'd you count it out at that point? Like, I don't mean that in a flippant way. I mean, I've seen a lot of bedside ultrasounds.
Yeah.
Where they're very helpful for the first couple of seconds, and then not very helpful because the person's in the way.
Yeah.
Of the resuscitation
It's like
that's going on.
it's kind of like the diminishing returns as time goes on, right? And that's how you look at the clinical situation. You have your pretest, and you have if they have pulse paradoxus, tachycardia, they're hypovolemic, and you look at it and you find it, and you say, well, of course you're going to start fluid the minute you see it, right? I think if they're in shock, they arguably should be getting fluid already, okay? And so I don't think you need to spend a lot of time on this. If this patient is an extremis, I think, once you're used to getting views, this could be a few minutes.
It's still a few minutes, though, not a few seconds.
Well, I mean, to be honest, it depends how good the views are, but it could actually be a minute. Yes, you could do it very quickly. It just depends how good the views are, really, and depends on the context, right? But the reality is, again, the most important part is they get fluids, okay, and you don't, avoiding a thing as what you're alluding to is a kind of fixation on this like very interesting pathophysiology. The point is get them fluids and get further consultation. Your 5-chamber, again, a large amount of intrapericardial fluid. Again, we would measure it here in diastole, not in systole, because it can make it look like it's larger here. That's the LV, there's the LA, there's the outflow tract aortic valve, and there's the right side, which we're not seeing very well, okay? And so in some cases you may not see this side very well, but when we see this is obviously quite concerning. There's the IVC. It's obviously nice and juicy with not much change there, so minimal resporophasic variation. And this IVC measured around 3 centimeters. And so again, we're seeing a bit of that stasis there develop in the IVC, and there's a hepatic vein. So case summary of this one is really, this is a likely chronic effusion. It's obviously quite large. It's been there for a while. She was still going for an operation. She dropped her preload likely with some induction, and that was enough to cause the manifestation of tamponade. So it's an important differential in unexplained hypotension, and it can be preload sensitive, the so-called kind of low volume tamponade, where someone's in equilibrium until we drop their fluid balance by either dialysis or some other acute means, even hemorrhage or dehydration. So this is a quick case, very quick, no stem, just this image. This is a horrible apical 4-chamber, which was thought to be a pericardial effusion. And there's an arrow here pointing at the structure. Okay, something is intermittently coming into view here. Okay, and any suspicion of what this may or may not be? Pericardial fat pad. Yes, that's one possibility. Usually we see that more in the RV. What else?
A pleural effusion of the lung coming in.
Nice. Yes, it is a pleural effusion with the lung. Okay, that's a false positive. Okay, that's actually a lung coming in. And the more you see lungs under ultrasound, the more you'll recognize that they're quite easy to pick up. Okay, so if you look closely, maybe I can convince you that there actually is a pericardial separation, and it's very, very small. Okay. Here's the actual parasternal lung axis. This person has an abysmal heart. Their left ventricle is extremely poor. They're gravity dependent on cardiac output, essentially. Yes, and so there's the pleural effusion, and there's the pericardial. It's very, very small. Again, it obeys those laws where it goes posterior to the thoracic aorta, and we don't see much in the anterior to the RV or RVOT. There's your normal reference. Again, to keep that in mind, you can look for that pleural effusion. So take home point number 1. Separation, pericardial separation is a common phenomenon in a critical ill patient. It's often an innocent bystander and not to let distract you from the main clinical problem. Take home point number 2. Identification of a concerning pericardial effusion requires that you consider the diagnosis of a pleural effusion. Okay, so that's, as I mentioned before, it's really important to consider that this is a frequent confuser of people, especially when starting out. They find these anechoic spaces and declare that there's a pericardial effusion, and it's almost certainly a pleural. So you can look for it, and you can look for those alternative views. You can look for further corroborating evidence. Take home point number 3, you can look for the physiological and hemodynamic consequences of card tamponade. Pulse paradoxis is your clinical equivalent of basically intraventricular dependence on echo. And so that is an important finding at the bedside, which you can do quite easily. And it's okay not to be certain. You can collaborate with your colleagues and peers and correlate with other clinical data. Okay, if they had a CT scan done that day of their chest and there's no pericardial effusion, it's pretty unlikely they have a pericardial effusion now. It's more likely pleural effusion. So that's the end. And you can follow me on Twitter. So that's the end. Any questions at all?